Good morning, everyone. Welcome to our inaugural NYU Brooklyn Cancer Symposium. Just a couple of housekeeping stuff. The restrooms are located outside the auditorium to your right, closer to the registration. The Wi-Fi information is posted in the registration. It's on this slide as well. And please remember to keep your phones on vibrate or silent for the entire symposium. And I'd like to welcome Dr. Brett Rudy, our EVP and Chief of Hospital Operation at NYU Langone Health Brooklyn, who will give us some welcome introduction. Thank you.
Great. Thank you, Oscar, and welcome, everyone. I think this is beyond exciting for everyone at NYU Langone and for the community. I'm going to go over a little bit about the hospital, but what has happened with cancer care in Brooklyn has been nothing other than amazing, meaning really looking at the entire person, at the family, providing world-class care, access to clinical trials, but done so that we really support patients through their cancer care and beyond. You already saw this, so I won't spend any time here. My background is actually in pediatrics and pediatric HIV. So I want to talk a little bit about the hospital. Just I think everyone has some familiarity with this. It's a moderate-sized hospital, over 400 beds. We have 11 operating rooms that will soon be going up to 17 operating rooms when we open our ambulatory care center, endoscopy suites, cystoscopy suites, and 5 interventional labs. Some things that people may not know is we're a level 1 trauma center, a comprehensive stroke center, a level 2 perinatal center, a center for SAFE, and we're magnet designated for the outstanding care that our nurses provide. As you can see, we're doing just shy of about 5,000 births, over 30,000 discharges, a lot of ED visits, a lot of cardiology interventions, and we're going to probably hit 14,000 surgeries and probably eventually 7,000 endo volumes. I'm looking at my endoscopy colleagues here. You know, we sit in Sunset Park, which many of you probably know, but it's probably the most diverse patient population in the country. And you can see the distribution here. I won't read all of these, but people come from all around the world and they live in this area, and they use us as not only their local hospital, but what we really wanted to do was actually say, how do we bring good primary care, good specialty care, but really high quality tertiary and quaternary care into Brooklyn? The whole approach here, when we merged with Lutheran in 2016, it's hard to believe we're now almost a decade into this, was not to take over a hospital, put our name on the building and say we're done. It was really, what can we bring to the community to provide better care to patients? Anyone knows that has worked in parts of Brooklyn? There are people that determine what care they get, determined by what's in their community. Going into Manhattan for many people is just not feasible. If you look at our region, we obviously get a lot of patients from Brooklyn, but we also get patients from Staten Island, Queens, a little bit from Manhattan. And if you look at the graph here, the image on the left, you will also see that we get patients from throughout Brooklyn. So even though our focus is Sunset Park and the immediate surrounding areas, there are certainly a lot of areas where we're hitting. Now, what did we want to do? In order to say that we're world-class, we had to prove that we are world-class. And I'm going to show you 3 opportunities here that we saw. First, getting patients out of the hospital quickly, better care, better access. We reduced our observed to expected length of stay by almost 30%, allowing us to go up on ED visits by almost 30%, and discharges up a little over 30%. And if you think about this, our bed base has not changed. So having the efficiency of getting patients back to their homes with the services and follow-up that they need is the only way we were able to do this. The other thing is, the question has come up, Did we really improve quality? And there are a lot of different metrics we can use, but I think there's none more powerful than mortality. And the graph here will show that the observed to expected, that means when you look at risk stratification for patients and who die in the institution, you're 70% less likely to die compared to some of the national benchmarks. And hospital-acquired conditions also decreased significantly by 80%. Better outcomes are not doing harm to patients, cutting down the use of central lines, using them judiciously, but also maintaining them carefully has led to a 77% reduction in CLABSI rates and a 97% reduction in catheter-associated urinary infections. I will say that right now we're over a year without a cardiac infection, so I'm going to knock on wood, but we really want this to be zero. And what we're looking at for our future, you're going to meet a lot of different physicians today who are going to be presenting some really interesting information of what we're doing with cancer care in Brooklyn. The folks in this room are the people that are the future of cancer care in Brooklyn, and I would say all of New York. You know, what we have done over the past few years, diversifying what we offer, cancer care, cardiovascular care, and starting an ECMO program. You're going to hear about plans for oncology today, particularly CAR T-cell and bone marrow transplant. We're opening a new ambulatory surgery center, which will not only house the ambulatory surgery and endoscopy, but we'll actually have space for PCC, our faculty group practice, and also for our family health centers. We have a huge network of federally qualified health centers that provide really outstanding primary care to patients. And we're really working to keep that well linked into access to cancer care, cardiovascular care, and eventually transplant, because little known fact is Brooklyn has the highest rate of chronic kidney disease in all of New York. And if you look at the number of patients who are offered transplant at the time they go onto dialysis, that is actually in the single digits in terms of access. Right now, we probably have the biggest kidney transplant program in the city. It's actually the best in the country. And if you look at it, we have a lot of patients that are coming from Brooklyn and NYU Langone. If you look throughout the state, we do more transplants in patients with Medicaid insurance than almost any other center. So that understanding that we have to bring that into the community to give people better access, do that closer to home. One of the biggest barriers to transplant is patients' access and transportation. Today, you're also going to hear from Megan Hasseltine around patient navigation. I think PCC, as you will see, this is going to be really what we do for managing most chronic diseases to try to keep patients engaged in care, break down the social barriers that patients have, and help them achieve better health. So with that, I am going to turn it over to Dr. LaHood. I really want to thank Oscar and Nina and the whole PCC for putting this together. I was never good at this in my career. It takes a lot of work, but not only, the work to put this together is really only but was able to be done because of all the work people did to get us to this point. So Oscar.
Thank you, Dr. Rudy, but I can barely take any credit. Anjana Sridhar here from the PCC and Danielle Verone from our communications team really helped put all of this together, and they did an incredible job. I'll focus more a little bit about what our Cancer Center focus has been on, and it's really to bring consistent care across our entire network at NYU. As Dr. Rudy mentioned, we didn't just put a tag of NYU on a random building. Let me just close this email, which, good. Sorry about that. Okay. So the idea is to bring the same level of quality, the patient experience, and innovation, uh, so that patient wouldn't have to travel anywhere else to get that. And to do so, we invested on a few things. Our infrastructures, both on the outpatient side, you'll see our Perlmutter Cancer Center in Sunset Park. We also have a brand new one in Cobble Hill, one in Midwood, and part of our new ambulatory hub will house our brand new outpatient bone marrow transplant center and hematology unit. And similarly, on the inpatient infrastructure, all of our patients are routed to our 4900 unit, where we have our expert uh, chemo-trained nurses and nurse practitioners. Um, and we're also building a brand new unit for bone marrow transplant CAR T cells. I'll tell you more about that later. Community outreach and education is something that we've been really dedicated to, and today is just one example amongst others. You'll hear more about the navigation from Megan Hasseltine later, and our clinical trials. The ultimate goal is to be completely seamless, the experience, whether it's here in Brooklyn, on Long Island, in Manhattan. You'll have, in a couple years, any clinical trial that we'll have in Manhattan will also be available in Brooklyn. That's a commitment from the Cancer Center and the hospital senior leadership. And the only way we can do that is by bringing high caliber people. And we've really brought on the very best. You'll hear later on from Dr. John Leonard, our head of the division, who came from Cornell, world-renowned lymphoma doc. We brought people from Columbia, from MSK, from MD Anderson, really cream of the crop. And the ultimate vision would be that, within Brooklyn, we have all these experts in cancer centers spread across the borough. And for more even advanced therapies, we have our sort of academic hub in Sunset Park where we run our clinical trials, where we're going to offer bone marrow transplant, CAR T cells, and those advanced therapies that need to be a little bit closer to an inpatient setting. We have some of our own faculty who lead clinical trials, both on the national and global level. And I'll tell you a little bit more about that later on in the heme section. We want to make sure that we're making it as easy as possible for external providers to refer patients to us. We have this curated email, pccreferrals@nyulangone.org, that for which one of our PCC administrator monitors and helps facilitate both getting the patient in quickly, but bidirectional communication between the referring provider, institution, and our own internal provider. And again, how we're going to expand in the future, both by the footprint and the clinical services that we're going to be offering. And really, we're the only NCI designated comprehensive cancer center in Brooklyn, Queens, or Staten Island. Later on, when I'm going to show you the volumes, people find it out, whether you've heard of it or not. At some point, when you start coming to NYU, you're not going to leave NYU, and you're going to want to get your care here. And I'll show you all the data on this later when I speak more about hematology, but the idea is, Dr. Rudy didn't really allude to that quite yet, but Brooklyn has the most populated borough out of all New York City boroughs, just by itself, in the top 2 to 3 most populated cities in the country. And no other institution has really invested in bringing true academic caliber care to the borough, and we've been fully invested in that. And so how we care for our cancer patients is not just with our exceptional cancer providers. We're among the very best in the country for every single subspecialty. So number 1 in neurology and neurosurgery. So some of our patients are going to get neuropathy and whatever other neuro complications. We will have world experts in this that can assess them. So for all supportive care, rehab, we're in top 5 in the country. Endocrine, I mean, you can see our overall, in terms of quality and safety, we rank consistently #1 by Vizient. In Leapfrog, we're A-rated, and we have magnet designation for our nurses. We really want to provide a wholesome, comprehensive experience to our cancer patients and to all of our patients, really, here in NYU Brooklyn. And to demonstrate the high caliber of our providers, I'm going to welcome the GI team and colorectal team up on the podium for now. Thank you all.
All right. Good morning, everyone. I'm Dr. Shahebar, Joseph Shahebar. I'm a colorectal surgeon. Adam Goodman, Casey Sahak. And this is our team. So it's myself and Dr. Krishnan. We're the colorectal surgery, and we have Dr. Goodman, Soroya, Dr. Viana, Dr. Sahak, Dr. Winograd, and everyone you see here. So Dr. Hill and Daniels, and all these people are typically on one of our multidisciplinary, one of our many multidisciplinary tumor boards that we meet on a weekly basis for certain types of cancers. So I don't know if you want to weigh in.
Sure. Thanks. So I'm Ken Siak, or KC Siak, and here's some of our various locations. You can see we're spread out throughout the borough. The main cancer center located in Sunset Park and 2nd Avenue, an additional infusion center in 70 Atlantic Avenue and Cobble Hill, and then multiple various practices elsewhere.
From a gastroenterology standpoint, we offer all advanced endoscopy services. So we do endoscopic ultrasound, that's including lower endoscopic ultrasound for colorectal cancer. We do luminal stenting for obstructions. We offer endoscopic mucosal resection for large colon polyps or difficult colon polyps. And we have started an endoscopic submucosal dissection program as well, ESD, for those complicated polyps as well in the colon. We have started a direct-to-procedure colon screening program. So any patient that needs to come in and needs colonoscopy for colon cancer screening can come directly without having to previously see a doctor to set that appointment up.
Okay, so pictures and videos are my favorite here. So when Dr. Goodman and his team, or Dr. Sayak and his team, find the cancer, or typically these patients are getting screening colonoscopies or coming symptomatically, they'll come to us and say, what's the next step? So, very task oriented here. We kind of operate by number here, paint by number. If the cancer's on the right side, we remove the right side of the colon, and so on and so forth. Where it gets a little bit more involved is in the rectum, which you see on the right lower part of the screen. And this is where our multidisciplinary care comes into play, and we'll speak about that a little bit later, because this involves radiation oncologists, surgeons, gastroenterologists, and of course the oncologists. So traditional surgery that we've been doing since the dawn of surgery is open surgery. Everything's there. It's nice and easy to see. The problem is that it's a higher incidence of hernia, more pain for the patient, protracted and longer recovery. And so, we've been pushing the envelope here for the last 25 to 30 years with laparoscopy. So this advantage here is smaller incisions, about the size of a fingernail, several small incisions using a telescope, and basically insufflating the abdomen with carbon dioxide so that we can see and do our dissection that way. So this is what a typical laparoscopic port arrangement would look like. But now we've, obviously the last 10 to 15 years, we've been using the surgical robot. We have 3 of them, maybe even soon to be 4 of them at NYU Brooklyn. We do our surgeries, I would say, as a standard, we try and do them minimally invasive when feasible, whether laparoscopic or robotic. This is what a typical arrangement looks like. And it allows the patients to have a quicker recovery because smaller incisions, less pain, less hernia risk. And we're actually able to reach deeper down in the pelvis and perform more sphincter-sparing procedures, meaning the patient will not need a permanent bag or colostomy or ileostomy. So just a little video of what it looks like. This is already a few years old, but you could see we really have a great view of what's going on. The tissue planes, you can take it really cell layer by cell layer. The surgeon themselves is controlling 3 arms plus the camera. I mean, it's almost like you're an octopus, because if you're operating open, you only have one hand to retract and one hand to hold, and you're really dependent on your assistant. And here, it gives the surgeon a lot more visibility and a lot more autonomy to view and operate in the sections that they want to. And we can get really, really low, almost down to the pelvic floor. So what I was referring to here, we can do lower anastomoses, lower connections by getting lower in the pelvis and saving the patients the need for a permanent colostomy. And this is another way that with the robot, we're able to do intracorporeal or in the abdomen anastomoses or connections. So we don't have to open them up just to put them back together. We can do it while their abdomen is insufflated with gas, and then just make a smaller incision to remove the specimen. Another thing that we've been working on the last few years is TAMIS, transanal minimally invasive surgery, which now we've been doing robotically. And basically, if you see on this cartoon, I didn't want to put a real body because it's a little graphic, but there's essentially a plug or a port that you put inside the anus itself, and you blow up the colon with gas. And similar to a colonoscopy, you're removing a polyp or a mass through the lumen of the bowel itself, except here, and this is the robot going through the port, through the patient's rectum. Here, you're able to see that not only are we able to remove the polyp layer by layer and go as deep, to the perirectal fat, we're also able to close the area. So let me just skip ahead. We're able to remove the polyp. You could see that's inside the wall of the bowel itself. And then as you go along, we get margins on the tumor. And this would potentially save the patient a much larger, what we call low anterior resection, or a larger rectal resection, so that they could spare them problems with defecation or even a temporary bag, and all the whole host of things that go with that. And so you can actually see the surgeon here is closing the defect, and Dr. Good will tell you, endoscopically they're doing this as well in some ways. So all this technology has been advancing. Future directions for the surgery team. I mean, in addition to expanding our robotics and minimally invasive, hopefully we'll get our single incision robotic colectomy. It's a special robotic platform. So that's something that we hope to have soon, and maybe transrectal or natural orifice resection. So we have removed colons, but mostly for benign disease, but sometimes for malignant, through natural orifices, whether it's the rectum or the vaginal cuff, if it was a combined surgery. And so one thing before I hand this over is that it's not just multidisciplinary amongst surgeons, oncologists, and GI, but it's amongst surgeons as well. So I work very closely with our gyn-onc colleagues, with our surgical oncology colleagues, with our urology colleagues. And so we're all kind of on the same page. It's a smaller hospital, a medium-sized hospital, so we kind of all know each other and personally, and we have a good working rapport. And so it's very easy to get together and do a big case, and we have all the parts there ready for us to use.
Thanks. So we'll be hearing a lot today about the multidisciplinary care, which is really essential for anybody with cancer. So for our colorectal cancer patients in particular, we have 3 specific weekly multidisciplinary conferences that involve surgical oncology, medical oncology, GI, dedicated radiologists and pathologists. So that includes our colon-specific tumor board, a separate dedicated rectal cancer tumor board, where all new rectal cancer patients are presented initially prior to treatment, and then throughout their treatment course. And then a dedicated hepatobiliary tumor board, which is nowadays critical for colorectal cancer patients with liver metastasis, in some cases, where we are aiming for a curative approach in those patients. Additionally, we have dedicated palliative care and supportive oncology teams who are available to do televisits, often during infusion clinic visits. If the patient needs some assistance, there's nursing staff who can help them log on to televisits while they're in the infusion center. You'll hear a little bit more about our other host of complementary services. So our registered dietitians meet with every new cancer patient during their initial chemotherapy visit and help the patient and their family members meet their nutritional needs, as well as our dedicated care of social workers and nurse navigators to help patients throughout their cancer care journey. For colorectal cancer in particular, and really all our GI cancer patients, they're reviewed at our weekly GI oncology section meeting to screen for trials and go over every new patient in the system. For our metastatic patients, our goal is quick initiation of therapy, so within 2 weeks of the initial visit. And for all stage 4 patients, molecular testing, typically tissue-based and/or liquid-based, is sent on all stage 4 patients and many early stage patients as well. And with the use of circulating tumor DNA, which is becoming increasingly important and helpful in GI oncology in particular, we incorporate that during their treatment course and surveillance when appropriate. And again, you'll hear a little bit more throughout the day about the coordination with the clinical trial team, both in Brooklyn and in Manhattan, for trials to refer to Manhattan for clinical trials, including with our phase 1 group. To briefly highlight one soon-to-be open trial in Brooklyn for colorectal cancer patients. So this is the Origami 3 trial. It's a phase 3 randomized study for second-line treatment of recurrent or metastatic colorectal cancer for RAS and BRAF wild-type patients. So a randomized study of amivantamab, which is a bispecific EGFR MET antibody, plus FOLFIRI, versus the control arm of either cetuximab or bevacizumab plus FOLFIRI. So a great clinical trial for the second-line metastatic colon setting. And then again, here's the dedicated email for PCC referrals at Brooklyn to be able to get your patients in quickly.
Good morning. I'm Brian Kaplan. I'm going to join this illustrious group.
Alejandro.
This is Alejandro. We're going to talk a little bit about our pancreas and hepatobiliary cancer care at Perlmutter. So this is our team, some of the same folks that were on the previous slide. Dr. Torres and I are based in Brooklyn, taking care of patients with GI malignancies, particularly pancreas, liver, bile duct. And then your advanced GI team, radiation oncology team, and medical oncology was outlined by my previous speakers. We see patients at the same locations. So that would be to repeat the PCC cancer centers in addition to some community practices throughout Brooklyn.
So again, we are fully trained advanced endoscopists. We offer quick and easy referrals for diagnosis. So a lot of diagnosis now in terms of pancreatic biliary cancer is coming through endoscopic ultrasound. We will get your patients in quickly. Actually got a referral from somebody yesterday via email, and that patient's coming in next week from outside of NYU. So we make it very simple, very easy to get in touch with us. We provide endoscopic ultrasound services. We also do ERCP stenting for those patients that need that. We are advancing our care and doing palliative procedures as well in terms of not just stenting, but now EUS-guided luminal apposition procedures such as gastrojejunostomies. So things that typically needed surgery in the past, we now will do endoscopically, which provides a quicker recovery for the patient as well as better outcomes potentially. And then we are doing direct-to-procedure endoscopic ultrasound program as well, where if we get all the we have our offices reach out, we get the information from you about the patient's history, et cetera, and we will just, if the patient is okay with it and not meeting us beforehand, we will get the patient into a procedure relatively quickly within usually a couple of weeks. If it's a tumor or obstruction or things like that, we will get the patient in within a week directly to endoscopy without having to see us first. So we're providing expedited care and advancing our care so that our patients are well cared for.
So talk a little bit about the surgical services that we offer. I think the key thing, and I think the theme that you'll hear, is that all patients, 100% with malignancies or pre-malignant conditions, are discussed at a multidisciplinary Cancer Conference. And to answer Dr. Leonard's question about, how do you get the word out? Well, I'm very specific when we talk to patients that we think that this is the approach, but we're going to discuss their case at our multidisciplinary care conference. And then when we call patients back after this discussion, they're always, their first words are, what did the conference say? And we generally, the conference agrees, but sometimes there may be a clinical trial that's available to the patient in Manhattan that we weren't aware of, or a new clinical trial that's enrolling. And we have the benefit of having not just one or two people seeing the patient, but the benefit of 30 or 40 people seeing the patient at one time. So this outlines multidisciplinary tumor boards that Dr. Torres and I participate in. There's the Pancreatic Tumor Board, which looks at patients with pancreatic cancers. There's also a pancreatic cyst tumor that addresses patients with pancreatic cystic lesions, which are sometimes premalignant or neuroendocrine tumors. There's the hepatobiliary multidisciplinary tumor board that was mentioned earlier. So we not only discuss colorectal metastasis, but primary hepatocellular carcinoma, cholangiocarcinoma, which is a tumor of the bile duct. And so all these patients are discussed 100% at multidisciplinary tumor board. I'm going to let Dr. Torres speak about.
Yeah, the other thing that I think it's important to note with regards to NYU Brooklyn and its capabilities, that it's very similar to what's being offered in Manhattan in terms of, maximally open invasive surgery for complex bile duct tumors or complex liver tumors, to also, robotic minimally invasive surgery for the same disease processes. And also a lot of tumors from the liver come from the colon. So we have a very strong relationship with our colorectal surgeons, and we can offer robotic surgery for, diseases that come from the colon to the liver. And it's not just being able to do it, but also to do it with excellent outcomes. And we've been able to do that for the past few years at Brooklyn. So I think when we talk to patients, not only do we tell them, look, we can offer you all the fancy operations, but you're going to have the outcomes that are equivalent to what's seen at high volume centers outside of Brooklyn. And patients want to hear that.
And I think the other thing that we have a significant patient referral base that's outside NYU, community providers, primary care doctors, gastroenterologists, and we all, everyone at the stage, and I think everybody in the room, really strive to keep clear lines of communication with the community providers, because that's important to the patient. Dr. Sehack's going to.
So again, as you've heard, once again, our multidisciplinary weekly pancreatic tumor board, and in particular for pancreatic cancer patients, universal germline testing is recommended and oftentimes is done at point of care testing during their initial medical oncology clinic visit. And we have a dedicated team of cancer geneticists to follow up on those results and go over in more detail. Again, for our metastatic patients, a goal of treatment initiation within 2 weeks of initial medical oncology visit, and the use of liquid and tissue NGS to really guide treatment, in particular for pancreas cancer, for clinical trial eligibility, which is essential. And use of circulating tumor DNA throughout their treatment course and surveillance when appropriate. And similarly, the whole host of supportive services. So supportive oncology, which is particularly important for pancreatic cancer patients, our social work, nurse navigators, and registered dietitians for comprehensive care. Just to talk a little bit separately about the hepatobiliary cancer care, as you've heard, our multidisciplinary tumor boards, in particular with the focus on local regional therapies. So our interventional radiologists are on there to talk about things like Y90, other ablative measures, and radiation oncology for SBRT when appropriate. So really individualized treatment planning for these patients, including systemic therapy with immunotherapy and targeted therapies as appropriate. And a relatively recent development with patients are very excited for is an on-site PET scan in Sunset Park. So they no longer need to travel into Manhattan to get their imaging, which is a great addition. And in particular in clinic, we try to make it as easy as possible for patients with same-day medical and surgical oncology clinic visits to really limit the visits that they need to come in for. So thank you. And we're
Hi, everyone. My name's Lindsay Moses. I'm one of our head and neck surgeons at NYU Brooklyn, and we're going to be talking to you about our program for head and neck cancer care at Sunset Park. So this is our team. That's me, head and neck surgery. Dr. Hill is our dedicated radiation oncologist for head and neck. He couldn't be here today, but he has a short video to share with you all, which we'll present. And then Dr. Sihak, of course, who you've heard from, and Dr. Sokolov for medical oncology. We all practice primarily at the Sunset Park location, which is our main cancer center, which is great because we can kind of see patients same day all together, and it's the same location where they receive their radiation treatments and their infusions. And so we can see them as well on an as needed basis. We can provide comprehensive care for all cancers of the head and neck. So that includes mucosal aerodigestive tract malignancies, including those in the nasopharynx, nasal cavity, oral cavity, oropharynx, hypopharynx, and larynx. We also provide care for cancer at additional sites in the head and neck that are non-mucosal. So I see a very high volume of salivary gland and thyroid disease. We can treat advanced skin cancers that are beyond the capability of our dermatology colleagues, treating unique cancers of the ear canal, temporal bone, and then some other non-malignant tumors, including paragangliomas and schwannomas. We describe our approach as sort of a co-localized, multidisciplinary, patient-centered care. This is a theme you've heard over and over today, that every cancer patient requires multidisciplinary care, and that we try to make it as simple and efficient as possible for the patients. So in the center circle around the patient, we have our surgery team, the radiation oncology, medical oncology, speech pathologist, social work. We're all really located at the same place, and most patients see us all on the same day. And so that allows them to avoid having many different appointments and trips. Transportation can be a challenge for many patients. And so we really try to work with them to work together as a team. On the outside of the circle, you see we have many other colleagues who are part of our team and who help provide care, depending on the patient's needs. So, the supportive oncology pain and palliative care team. For head and neck specifically, we work very closely with interventional radiology when we need biopsies in challenging locations. We have dedicated head and neck pathologists. We work with our endocrinologists. We have a robust thyroid program with endocrinologists who specialize in treating thyroid cancer, and our oral and maxillofacial surgery colleagues. So a large multidisciplinary team. A lot of repetition here, but again, we also have a multidisciplinary head and neck tumor board, which meets once weekly. We review all of the new cancer patients. This tumor board is combined between all of the NYU campuses, so it includes patients and providers from NYU, Brooklyn, and Long Island, as well as our affiliated hospitals that we as a department treat, including Bellevue and the VA hospitals. We have dedicated neuroradiologists, nuclear medicine specialists who help review our imaging studies, dedicated head and neck pathologists to review our biopsies, many of whom have decades in head and neck cancer experience. The social workers and dietitians, as you've heard about, are a part of our supportive team, as is the supportive oncology group. One of the things I want to highlight is that, our efforts are to provide care for the patient sort of across their entire journey. And that includes, from the day they present until the day they pass away, essentially. And so, at initial visits, they'll get biopsies performed, we'll perform imaging, we'll connect them to resources in the community. We have a network of community health workers, nurse navigators. All of our patients get a pre-treatment SLP evaluation with our dedicated head and neck speech pathologists. They get a swallowing evaluation. Treatment for head and neck cancer almost universally will affect patients' speech and swallow in some way. And so that's a really critical part of our program. All patients receive a dental evaluation prior to undergoing radiation, and we have a collaboration with our FHC dental clinic next door to help facilitate that and expedite referrals so that they don't delay treatment. On the treatment side of things, obviously we provide, surgery, radiation, chemotherapy, immunotherapy, Patients receive ongoing speech therapy during their treatment course, and then toxicity management sort of as needed. But then survivorship is also a mainstay of our practice. So, we continue to see patients, I continue to see patients really ongoing forever after they've been treated. We perform routine surveillance exams. We monitor for long-term side effects of treatment people can experience, such as hypothyroidism, carotid stenosis, peripheral neuropathy, xerostomia, dysphagia. The sort of effects of cancer treatment can be long-lasting. And so we continue to see patients and help to provide services for those treatments for radiation fibrosis. Our speech therapist is a certified lymphedema therapist. And so we really develop these long-term relationships and provide care for the patient. So a little bit about my practice, treating both benign and malignant lesions of the head and neck. So I'm a head and neck surgeon. I also perform microvascular reconstructive surgery to help put people back together after needing resection for head and neck tumors. In the office, we can provide ultrasound-guided FNAs and biopsies. We have a cytotechnologist who comes from the hospital to prepare slides and check biopsy specimens with our pathologist to make sure we're getting good samples. That really helps expedite care. Patients can have that done on the first appointment so that we can obtain a diagnosis and get the ball rolling for their treatment plans. Perform the full spectrum of head and neck surgery, small procedures such as lymph node biopsies or core biopsies if they're needed to help with the diagnosis of lymphoma. Provide or from a pretty high volume of thyroid surgery, salivary gland surgery, and then treating larger mucosal tumors that require things like a laryngectomy or a complex resection and reconstruction. Small procedures can be performed in the clinic under local anesthesia. And we're able to do a fair amount of things in that setting for patients who either are medically complex or prefer to avoid the operating room. Larger surgeries are performed in the operating room at NYU Brooklyn Hospital. And I just want to note that in addition to everything we've talked about already, we collaborate with colleagues in other specialties whenever necessary. These patients have complex problems involving the head and neck is a small and complicated space. So I work with neurosurgery, with facial plastic surgery, oral maxillofacial surgery, all of these different colleagues, depending on the needs of the patient, so that we can give them really the best outcome. Do you know how to play this video? You know this one? Okay, so this is from Dr. Hill. He's our radiation oncologist. He's sorry he can't be here, but this is a short video he made to talk about our...
Hello, everyone. My name is Carl Hill. I'm a radiation oncologist at NYU Lake. I practice in Manhattan and Brooklyn. So I'm really sorry I can't be there with you in person today, but I decided to share a quick overview of what we're doing in radiation oncology at NYU Perlmutter Cancer Center in Brooklyn for our head and neck cancer patients. So our focus is all about precision radiation treatment, tailored patient-centered care, using the most advanced technology available. We use modern, high-multi, intensity modulated radiation therapy to deliver highly targeted radiation that conforms closely to the tumor while protecting the healthy tissues around it. We also have the ability to do adaptive radiotherapy, which lets us fine-tune treatment as patients change during treatment, whether that's due to the anatomy, tumor shrinkage, or weight loss. It is safe to do so, like for low-risk HPV-positive warfare cases. We are incorporating treatment de-escalation, helping us maintain excellent control rates while minimizing treatment toxicity. In addition, at NYU, we have access to SBRT and proton therapy, which allows us to individualize therapy for even the most complex cases. Of course, none of this happens in isolation. I work very closely with Dr. Moses, Dr. Cisak, and Dr. Sokolov, so that surgery, systemic therapy, and radiation are all carefully sequenced. Our head and neck group is also developing immunotherapy and radiotherapy clinical trials in the pipeline, which we expect will open exciting new options for patients in the near future. Finally, we place a strong emphasis on quality of life and toxicity management. We take a proactive approach to manage these side effects, both short and long term, with the help of our supportive care and survivorship teams. The goal isn't just to treat the cancer, it's to help patients recover fully and leave well afterward. So thank you so much for your time. And I look forward to hearing about how the symposium went today and how this will help us continue to build our head and neck program in Brooklyn. Thank you. Hello, everyone. My name is Colorectal. I'm a
All right. So from the medical oncology perspective, again, as Dr. Moses said, all our visits are coordinated the same day. You know, the cancer center is 2 floors, so patients see ENT and radiation oncology on the first floor and then come up to the second floor for us in medical oncology and any infusions they may be getting. Incorporation of the latest immunotherapy, chemotherapy, and when appropriate, targeted therapy for all of our head and neck cancer patients. And shared decision-making is important for head and neck cancer in particular, due to the sometimes various treatment options. Again, everything's in a single location, so easy for the patients. And we often have the ability for urgent assessments, same-day visits if needed for a toxicity check or IV hydration and symptom management in the infusion center.
Yeah, I just wanted to mention briefly about our speech language pathology team. They've come up a few times. They're really a critical component of being able to provide high quality care for head and neck cancer patients. So they provide comprehensive head and neck communication and swallowing rehab services. We have a dedicated head and neck speech pathologist, soon to be 2 of those. She sees all of our patients pre, during, and post-treatment. She's also a certified lymphedema therapist. We have many speech pathologists also who work on the inpatient side of things. So our patients after surgery, they begin seeing the speech therapist right away. They do sort of pre-surgical education about what to expect. And that's been a really important component of our care. Our speech therapists have also really engage with the community. They've started a laryngectomy support group for patients who've undergone laryngectomy surgeries, and they can meet with each other and share their experiences and meet with new patients. And so it's been nice to see them sort of engaging in the community even outside of the hospital. So just wanted to share that aspect of care.
And then just to highlight briefly 2 head and neck specific clinical trials currently open in Brooklyn. The first is a phase 2 study looking at the radiosensitizing compound VS101. This is for patients with locally advanced head and neck cancer undergoing definitive radiation. So either randomized to the standard of care, chemoradiation therapy, or in 2 dose levels of this compound, which is essentially aripiprazole and has shown activity as a radiosensitizing agent. The second is for adjuvant, in the adjuvant setting for patients who have undergone resection and have high-risk pathologic features. So a randomized phase 2/3 study looking at standard chemoradiation with cisplatin and 2 experimental arms, either RT with docetaxel and cetuximab or RT with cisplatin and atezolizumab, so the use of immunotherapy in this setting. And I know you'll hear more later today about additional clinical trials in Brooklyn. Again, here's the referral email, and thank you, and happy to take any questions.
Good morning. My name is Alyssa Sokolov. I'm a medical oncologist. I practice thoracic lung cancer oncology in Brooklyn in both Sunset Park and Cobble Hill locations. So I'm excited to present this part. So lung cancer in Brooklyn, it remains a significant challenge. Approximately 11% of all cancer diagnoses in Brooklyn is lung cancer cases. However, it remains the leading cause of cancer death in the borough as well as nationwide. So specifically, lung cancer-related deaths in Brooklyn the rates have decreased over the past 2 decades, and that specifically reflects improved access to care and improved care in lung cancer oncology. So we are going to aim to improve on those numbers further. So NYU Langone delivers state-of-the-art care in all cancers, including lung cancer. And we're looking to bring all of this care to Brooklyn that's going to be on par with Manhattan care that we provide. We're improving on the array of modalities tailored to individual patient care, their characteristics, stage, and their health status, which is important for lung cancer patients. A lot of them are frail. So patients have access to full spectrum of diagnostic treatment modalities here in Brooklyn locally, and we have access to clinical trials and also novel therapies. So our team, again, to repeat and reiterate what everybody has said before, we employ multidisciplinary team approach to each patient. There is individualized treatment plan for each patient. We participate in weekly thoracic tumor board conferences. We discuss challenging cases, always devise a plan for each patient individually. So in Brooklyn, residents can receive advanced care here in Brooklyn without leaving the borough. It's very important for our patient population because a lot of them are, rely on portable oxygen. So we don't want to create anxiety for these patients traveling car service to Manhattan with their oxygen tank dying, etc. So, they also benefit getting treatment closer to home. So we are proud to say that we're a multilingual oncology lung Brooklyn team in Brooklyn. So we speak Mandarin and Cantonese. We speak Russian and Spanish. We also provide, obviously, the professional interpreter services as we should, but we are able to make those connections with our patients because we speak their language, and a lot of times, make their experiences a lot more comfortable. We also utilize this new approach of electronic consult, which is very important for thoracic oncology because we can answer some of these questions related to treatment toxicities within minutes, actually. So it is a official curbside. We have it in 3 specialties currently, including palliative care, supportive care, endocrinology, and also dermatology. So for patients who rely heavily on immunotherapy, both endocrinopathies and skin conditions are very common. So I have utilized this multiple times over the past few weeks, and we get answers within minutes, and we can provide expedited troubleshooting for immunotherapy-related side effects. So also a palliative care team is very integrated into thoracic oncology care. We have very close access to them. They provide a lot of telehealth appointments within a couple of days. Usually we're able to get care to our patients. We're also excited to say that we are going to be bringing a palliative care provider. I think the estimated date is March to be on site. So as far as diagnostic modalities go in lung cancer, it has been really exciting. A couple of months ago, we brought PET scan to Brooklyn, so that actually dwindled waiting times and streamlined care for our patients and diagnostics. We have MRIs available also like at Cobble Hill location with very fast access to care that way. We have access to Dopplers, vascular imaging, as well as echoes and PFTs, very important. So as far as pathological diagnosis, multidisciplinary approach at NYU is something we employ across the board. So we usually discuss challenging cases in real time with our pathologists, add some tumor markers. Target mutations like EGFR and ALK are included in the initial pathology report for all of our non-small cell cancer patients, as well as PD-L1 status. So that helps us expedite care with systemic therapy. Also, we employ, as Dr. Seahawk said previously, liquid biopsy as well as tissue biopsy for new generation sequencing for most of our patients, if not all of our patients with lung cancer. So that provides access to less likely and less common mutations such as ROS1, NTRK, RET, and we can that way streamline patients to clinical trials based on their molecular biology of their cancers. So as far as therapeutics, chemotherapy, immunotherapy is available at all locations. It's going to be completely replicating what we can offer in Manhattan. We can expedite access by being able to offer systemic therapy at all of our 3 locations in Brooklyn. Also, I'm proud to say we are very well integrated with radiation oncology. We provide integrated care for these very complicated cases where we need to combine chemoradiation together. We always discuss every case. We expedite care because we were able to coordinate that very nicely. So TKIs or tyrosine kinase inhibitors are very important also for lung cancer patients with driver mutations. We rely heavily on NYU Langone Specialty Pharmacy. So the experience with that is also incredible because they provide education to the patients as well as troubleshooting for side effects and expedite financial clearances. Even if the medication is sometimes not covered by insurance, we're able to get patients to care with help of our specialty pharmacy. So as it has been mentioned, there's access to a myriad of clinical trials. We're looking to open more thoracic trials in Brooklyn, but we know our patient's biology, molecular biology, and we'll always look out for a patient who will benefit from clinical trial. We're looking also to improve and expedite our CAR-T availability, and we're looking to become one of the national leaders, and there's a lot of effort in NYU Langone in that direction. So I think soon we'll bring CAR-T to Brooklyn as well, has been mentioned. And I can't emphasize enough our collaborative effort with supportive care, supportive oncology, palliative oncology, also social work, nurse navigators, and nutritional dietary support. So it's an exciting time to be in thoracic oncology in Brooklyn, and I will hand it over to Dr. Mercado, I think, right?
Oh, there you go. I guess so. Well, yeah, you can see. Hi, my name is George Mercado. I'm the head of pulmonary in NYU in Brooklyn. You can see the locations here that Dr. Sokolov mentioned for our access to medical oncology in Brooklyn. We see also a location in Rego Park in Queens. So as you know, we have mentioned here, there's a lot to be said about multidisciplinary care. Right now, we are running behind in terms of thoracic oncology and lung cancer diagnosis and treatment for our colleagues in breast and colon because we came late in the game of screening for lung cancer. And the reason why it was very difficult to find lung cancer early and was always diagnosed late. So as Dr. Sokolov mentioned, the last 20 years have been remarkable in the way that we have been able to change cancer care for the lungs. So one of the things that we have done is they started the screening programs, was first published 20 years ago, and it has been very slow moving needle to try to increase the screening for lung cancer in the world and specifically in New York City, where we're lagging behind worldwide and nationwide, and here's no difference. But here at NYU, we have taken the lead into creating a lung cancer screening program that along with Manhattan and Long Island, we take a look at our patients that smoke between the years of 50 to 80 and having quit smoking within the past 15 years. And we're offering a low dose scan, a low dose CAT scan, so that we can see if those particular patients have a lung nodule that we have to go after. Now, in order to, every time that we see these lung nodules, we have to actually go in and diagnose that lung nodule. We need to get a biopsy. So here you see, you heard from Dr. Rudy how we have acquired the hospital in 2016, and this is how we have the timeline that in Brooklyn, we have introduced technology to advance the diagnosis of these lung nodules and being able to diagnose lung cancer early. So we have acquired first a bronchoscope, then an endobronchial ultrasound, then a robotic bronchoscopy in 2021 with a radial ultrasound. Then we established the nodule board, which is basically seeing every nodule that we have been able to identify in the lung cancer screening program. We discuss it in a multidisciplinary approach. You're going to hear a lot about that, but basically that's a lot of experts discussing to what to do with that lung nodule. And then lately last year, we were able to incorporate technology in advanced imaging while we're going after that lung nodule. So what does that mean is that when I am going after a lung nodule in the operating room, not only I am able to go after very, very small nodules, smaller than 1 centimeter, but also I'm able to stage those lung cancers. So I can give it to Dr. Sokolov or Dr. Nishimura, not only with a diagnosis, but also with a stage, which is very, very important for lung cancer. As we know that the earliest we can find the lung cancer, the more options that patient is going to have. This basically is quoted with the use of advanced robotic bronchoscopy. So we were able to utilize many of these platforms, and now we have the latest technology, the ion robotic bronchoscopy, the one in the middle, and that really allows us to not only being able to navigate towards the nodule, but really try to obtain as much tissue. For Dr. Sokolov, she keeps emailing me every other day to say, "Give me more tissue." But now we are able to actually do that in a more precise manner, so the patient minimizes the amount of biopsies that the patient or procedures that the patient has to have. Just thinking about it, this past week, we also did a case with Dr. Goodman that you heard from, the GI specialty. Together in one single anesthesia event, we were able to both go to the stomach, and then I went in with the robot to diagnose lung nodules, and being able to confirm the diagnosis of lymphoma on a patient very elderly that could not have probably endured 2 separate procedures. So this is the kind of things that we can offer at NYU in Brooklyn. This is our team, Dr. Lankowski. He's also in locations at NYU in Brooklyn, and does cases alongside with me for the diagnosis of these lung nodules. You can see here that the locations in Brooklyn are spread out. As Dr. Kaplan was mentioning, we get patients all over the county, and also outside. I've seen cases in New Jersey. In fact, I got a case from California that came specifically to see me. I don't know why, but they came. And she heard my name, looked it up, and then says, like, "Oh, I want to have my case done with you." What basically that says is that not only we're focusing our community here in Brooklyn, but we're becoming a name outside of New York City, and becoming famous for the things that we are doing here. These are the amount of bronchoscopy that we have done so far. It's impressive for the CESA single. If you think about just not only less than 10 years ago, we were a single community-based hospital in the middle of Sunset Park. And since then, we have been able to move the needle, have a stage shift that we call being able to diagnose lung cancer earlier, and provide care for patients here, residents here in Brooklyn. With numbers and volumes also comes quality. Dr. Rudy mentioned that in his talk earlier, and our quality is beyond what we can expect nationwide. So one of the things that happen when you put a needle inside a balloon is that it can deflate. So pneumothorax is something that happens when you go after very, very small nodules, especially. And we only had about 3 pneumothorax instances in like hundreds of cases in the last years. So that's something that we should be proud of. Not only we can provide these patients with an accurate diagnosis and staging and then treatment, but also without causing any complications or side effects. And that's something that we strive for here in NYU in Brooklyn. So here to talk about my colleague, Dr. Nishimura.
Good morning. Thank you for being here today and taking the time out of your day. My name is Jennifer Nishimura. I'm one of the thoracic surgeons here at NYU Brooklyn. One thing that I noticed about patients that are diagnosed with lung cancer, one, it's a very hard diagnosis to have for the patient and the family. Sometimes it comes at them at a complete surprise. So it's very hard, and we do want to get them timely care for a good oncologic outcome, of course, but I think in part there's a lot of anxiety that surrounds this diagnosis. And part of it is they don't know what to do. They don't have a plan. When people have a plan, they kind of feel better about it and they feel like they have, a chance or something. So the clinic here at NYU Brooklyn, they are committed to getting patients in a timely fashion. So the leadership has committed to getting them in hopefully within a week or two for almost all of our patients. There's also direct access, as you guys probably know, where patients can book their appointments directly through Find a Doc. Also, we do offer personalized care. We understand that every patient is different. Like Dr. Sokolov was mentioning, a lot of them may be frail and maybe surgery is not the best option for them. And, that's absolutely fine. They also, or maybe they are, excellent surgical candidates physically, but, as far as their goals in life and, their preference to quality of life, they may elect to go non-surgical options such as, radiation therapy. So we do kind of take this into strong consideration to get the patients the best care that fits for them. We also do take a team-based approach. Having lung cancer requires a lot of support, and that even starts before the patient sees the provider. There's a lot of coordination that goes on behind the scenes, and there are multidisciplinary tumor boards, things like that. But when you get a cancer diagnosis, so especially for lung cancer, we also follow you for a very long time through surgery, after surgery, and with surveillance. So it really does take a big team, and the team here is committed to ensuring that the patients do get the care that they need and what is best for them. And, for thoracic surgery, we are committed to providing patients, almost all of them, with minimally invasive surgery. This does reduce their pain after surgery. It's an easier recovery for them. There's less risk of wound problems after surgery. Patients do tend to prefer the minimally invasive approach. And I think as you saw in the colorectal surgery videos, like the visualization is excellent. So I think that really does help with patient outcomes, including oncologic outcomes too. So at NYU Langone Health, the system in thoracic lung surgery, we are ranked to #1, and that does include the NYU Brooklyn facility. And in the previous year, they are also ranked #1. They were tied with another institution, but this year we are standalone #1 in lung surgery. That demonstrates the commitment to quality of care and excellence in lung surgery here. In addition to lung surgery, as far as thoracic oncology is concerned, we also do surgeries for thymomas, mediastinal tumors, and other things such as metastatic disease that have spread to the lung. Where sometimes, for example, if you have a colon cancer that has spread to the lung, sometimes patients are a candidate to have that part of the lung removed to help them with their overall prognosis. Thank you. Oh, sorry. We see patients at 2 sites, at the Sunset Park site and then also in Diker clinics. I believe where we are, we work with pulmonology on the same day, so that can really help patients get their care faster.
Good morning. I am Megan Hazeltine. I'm the Director of Patient Navigation, which includes social work and the cancer screening programs at the Cancer Center. And I'm here with my colleague, Victoria Foster, who is going to introduce herself in a few moments. So we've heard patient navigation mentioned in the presentations this morning, and we wanted to give some time to just explain more thoroughly about our program. As many of you know, when somebody receives results for a suspicious finding or is diagnosed with cancer, there are lots of emotions that can come up: fear, shock, anxiety. lots of questions, especially when somebody is diagnosed with cancer, not understanding what specific tests are for, what their prognosis is. Can they afford the treatments? That's a big one. Can they still have children after treatments? And many of these questions and concerns can impact a patient's ability to understand and engage with their care. At PCC, we are committed to centering the patient, and we've invested to build programs such as the patient navigation program that really support patients in addressing these concerns so that they can feel engaged and supported throughout their treatment. Just to give some history of patient navigation, because I think a lot of people hear the term, but they may not know what it means, or they see different versions of patient navigation programs. Patient navigation is a healthcare service, and it's designed to help individuals overcome barriers so that they can get care in a timely fashion, treatment. It was originally developed to address underserved populations, but it's been shown time and time and again that it helps all patients better understand their care and get through care in a more timely fashion. So it started in the 90s in breast cancer. The very first program was in Harlem Hospital, where Dr. Harold Friedman was working with breast cancer patients who were missing their appointments or weren't understanding their disease. And when he probed further, it wasn't that there was a lack of desire for treatment. It was that there were social things happening in their lives that impacted their ability to get care. And so he created a patient navigation program there that showed that having navigators in place increased knowledge, reduced barriers to care, and improved access and time to treatment. In 2005, there was the Patient Navigation Outreach and Chronic Care Act that was created to expand patient navigation programs across the country. And in 2010, this expanded even more to address HIV, patients with HIV, diabetes, and other chronic care and prevention issues. And then in 2020, you may remember seeing people out in the community educating about wearing masks and getting vaccinated. And so patient navigation continues to evolve and expand, but over this continuum, it continues to show that it improves access, reduces disparities in care, and increases survival rates. Patient navigator role specifically. So patient navigators can be social workers, they can be nurses, they can be community health workers, and we'll talk about our model in the next slide. Some of the main roles are facilitating care. So we all know how complicated our healthcare system is in the United States. Especially when you have cancer, it can become even more complicated. Our role is to help make sure that patients get the care they need fast and that they're able to understand the reasons why we are suggesting and recommending that they get that care. We help with scheduling and coordination. So we connect people to different practices if they need to see a cardiologist or a dentist before they start treatment. We provide a lot of education. We want patients to know why their physician is recommending certain things, certain forms of treatment. We want patients to have autonomy in their decision-making. We do a lot of advocacy, so preparing patients for their appointments with their doctors, debriefing with patients after their appointments with their doctors to make sure that they do understand their care. We also advocate within the healthcare system. So if we notice that there are certain barriers within our system that may be impacting a patient's ability to get timely care, we work very collaboratively with the leadership at NYU Brooklyn and the Cancer Center to make sure that we can address those barriers as quickly as possible. We also work to remove social barriers, so transportation, finances, things like that, that may be impacting their ability to come to their appointments or get care. We have a wide range of resources that we connect people to. That could be connecting people to benefit assistance. It could be support groups, things in their community that they not only need to help get them through their cancer treatment, but also would be beneficial to them after they've completed treatment. And we do a lot of follow-up and monitoring. So making sure that we talk to them after their appointments. We, especially in transitions in care, that they understand if they've completed surgery, why they are moving to chemotherapy, or why they may need radiation before surgery, to make sure that they understand what is going on. Our model in Brooklyn is we have 3 different components. The first is being out in the community. Our community health workers do a lot of outreach to Dr. Leonard's earlier question, making sure that people in the community are aware of the services that we offer, and that we work very hard at NYU to ensure that they have access to these services. Our community health workers also focus on the social drivers of health. We also have clinical navigators. We've heard in earlier presentations about nurse navigators. They go over with patients questions about their clinical care. They address clinical barriers to care, and then they are key staff to help facilitate the transitions in care. And then our social workers provide psychosocial support to address the emotional needs of patients, and that includes offering support groups. This is our team. I feel very lucky to work with such an amazingly dedicated team. They are very skilled. We have staff that speak Russian, Spanish, Cantonese, Mandarin, Fujianese, and Arabic. So we try to make sure that language is not a barrier for our patients, in addition to being well-versed in the resources that are available in the community. We also, many people in our staff are from Brooklyn. They know the communities that the patients are coming from. We go out into the community to do presentations. Our goal, as I mentioned earlier, is to help people stay connected to their community or become more connected to their community. We want to make sure that if somebody completes treatment, that they are able to have access to services in their community continue. And then just an overview of the numbers that we have done so far in 2025. We've gone out and completed over 50 educational events. If you would like us to come out, we are willing to come out and educate your patients. We have, our community health workers have worked with over 2,000 patients. We work with people from prevention through treatment into survivorship. Our nurse navigators have worked with over 500 patients, and our social workers have worked with over 500 patients. And I'm going to turn it over to Tori to show a patient story.
Hi, friends. Ooh. I'm Victoria Foster, Tori, never Vicky. Don't try it with me. And I'm the program director of the Community Outreach and Engagement Core for the Cancer Center. I think we all know that a lot of health happens outside the clinical environment. And so when we started the Community Outreach and Engagement Core, I did a listening tour. I went out to a number of faith-based and community-based organizations and asked people what they would want to see from a truly comprehensive cancer center. And over and over and over again, I heard, we know that NYU is full of geniuses. We know it's very elite, but we don't know if it's for us. We don't see images of people that look like us or people that speak our language in health communications. And I said, very affirmingly, NYU is here to take care of you. That is why we are literally in your community. And they said, that's lovely, but we need to hear it from within. We need our own communities to say it to us. And so I have worked over the past few years to support Megan and her navigation teams, and we are developing a series of videos. You will see the first one, which is in Spanish and rooted in Brooklyn. You will see how rooted in the community it is. We're going to do others in Russian, Arabic, and Mandarin as well. And I would also like to say, if you are a community member or you're a doctor or researcher and you're interested in community engaged work and strategic planning, come talk to me. I would love to work with you. Also, if you'd like to show these videos, let me know. This is, again, the first, and thank you all so much, and thank you to Megan for all the support she's given over the years.
Mi pasión por la salud comunitaria es un proceso que vale la pena.
Definitivamente hay gente que ahí siempre está su granito de arena para ayudar.
Cuando pienso en la comunidad de Sunset Park, me siento muy orgullosa de formar parte de una comunidad que es multicultural, bien trabajadora, que se apoya y tengo el privilegio de poder servir a mi comunidad.
Mi nombre es Roberto, soy mexicano, soy un paciente de cáncer. Empecé con síntomas como en las noches a levantarme frecuentemente a orinar, pero no podía orinar completamente, eso tenía que ir constantemente. Me hicieron la prueba de la próstata para detectar el cáncer y cuando a las 2 semanas me dio los resultados, resulta que yo ya tenía cáncer etapa 4. Yo quería estar bien por mis hijos. Cuando yo me enfermé y dejé de trabajar, yo pensé, o sea, pensaba, ¿y ahora cómo voy a hacer? Porque yo era el sustento de la familia. Bueno, hablé con la familia y de ahí decidimos ir a tocar puertas al NYU. Y gracias a Dios nos recibieron y de ahí yo empecé mi tratamiento.
Soy promotor de salud comunitaria en el Centro Oncológico de NYU, una posición que incorpora la conexión entre el paciente y el sistema de salud. El Centro de Oncología toma un orgullo en tener sus promotores de salud comunitaria basado en el lenguaje, que hablan diferentes tipos de lenguajes para asimilarnos a nuestros pacientes. Hola, ¿cómo ha estado?
Bien, Damián, vamos ahí un día a la vez.
Cuando empecé a trabajar con mi paciente Roberto, el hecho de que inglés no era su primer lenguaje, estaba en una situación muy vulnerable.
No sabemos a veces a quién recurrir y la ayuda que nosotros nos han brindado. O sea, a mí personalmente, mi familia y yo estamos muy agradecidos. Yo trataba de buscar víveres para mi familia y yo le comuniqué a él, le digo, ¿sabes qué? Mira, pasa esto. Dice, mire, le voy a mandar una lista de asociaciones que ayudan o que proveen comida. Dentro de esas venía Raising Health.
La conexión con Raising Health y NYU ha sido una relación bastante fructífera. Nuestra meta es poder ayudarnos y apoyarnos para brindar el acceso médico de calidad a nuestra comunidad. Cuando tenemos el apoyo de alguien en que confiamos, que nos motiva, que nos ayuda a realizar nuestros sueños, es mucho más fácil.
La comunidad latina a veces somos un poco más escépticos y aguantadores. Tienen que checarse. O sea, yo les digo a ellos, chequense, nunca es tarde para determinar cualquier cosa.
Gracias a usted, señor.
Cuídese, Dios me lo bendiga.
And most of all, of course, we want to thank Roberto and his family for opening up their house and this incredible story of real triumph. Thank you so much.
Good morning. I'm Dr. Donna Marie Manassi. I am Chief of Breast Surgery at NYU Brooklyn Breast Program, and I'm happy to be here to introduce our program. Beside me is my amazing colleagues, Dr. Zelenko, Chief of Radiology, Imaging, and Breast in Brooklyn, as well as Dr. Diabrio, Chief of Medical Oncology in Brooklyn. I'll start with why even consider a dedicated breast program. Frankly, everybody knows someone who's been diagnosed with breast cancer. Sadly, some of us know women who have succumbed to the disease. In Brooklyn alone, the incidence of cancer, the #1 cause of cancer in women is breast cancer. Unfortunately, the #1 cause of death from cancer is breast cancer. So it's very common, and we're here to hopefully change that experience for women in Brooklyn. Breast cancer diagnosis and treatment has become increasingly complex. This is actually a good thing. It means we have more ways of diagnosing breast cancer, more ways of treating breast cancer. We know early detection improves survival. Get your mammogram, get your ultrasound, get what you need to get screened, we'll find it. The question is what happens after that? This is where a multidisciplinary approach improves patient outcomes, the type of approach that we provide at NYU. But this happens with enhancing our continuity of care between our team and yours and the community. This happens with the community's assistance. When we look at breast cancer treatment, historically, it was very simple. You saw a surgeon, you saw a radiologist, you saw medical oncology, radiation. We each had something to offer, but it was very limited in what we could offer. And this was because of what we knew about breast cancer. Today, as evidenced by this crazy busy slide, which I don't expect you to be able to be read, there is a quiz later, but feel free to, do what you need to do. Where we understand risk factors better, we understand tumor growth and progression better, and we understand the treatment options. And as a result, our treatment options have become a lot more complicated. You have surgery, radiotherapy, endocrine therapy, immunotherapies, and targeted therapies to try to help these patients. So what was traditionally very limited treatment and diagnostic options has become a lot more complicated from the radiology side. I'll let Dr. Zelenko go into a little bit more, but we've gotten different options for mammography, ultrasound, and MRI, and ways we biopsy and find the disease. From the surgical side, there's a plethora of surgical options. And even when it comes down to saving the breast, there are cosmetic ways that we save the breast. Historically, in mastectomies, we used to remove the nipple on all patients. We don't do that in every patient. We can save the nipple and save the sensation in the nipple as well with some of our patients, including some amazing reconstructive efforts. Medical oncology, that field just keeps growing with respect to what is possible in terms of preventing this disease from taking a patient's life, and radiation oncology controlling locally in many different ways instead of just one version of a technique. As part of the PCC network, we bring this strategy to Brooklyn. We provide that one exceptional patient experience, that one world-class quality, and that one commitment to cure cancer right here in Brooklyn. For surgery, our locations are either at the PCC sites or nearby, both in Cobble Hill, the Sunset Park area, and in Midwood. This is my incredible team, which if I'd shown you this slide about a year ago, half of these people would not have been on it. We continue to grow. There is a real passion among every team member you see here to provide the care that we feel the patients of Brooklyn deserve. On the top is breast surgery, because we're breast surgery. Myself, my partners, Dr. Sargent and Dr. Kumar, we see patients at Bay Ridge, Cobble Hill, Midwood. I'm a medical oncology team, which is getting bigger than the surgery team. We'll talk about that later. But it's led by Dr. Diabrio, our radiology team. Too much to mention, but Dr. Zelenko will go into that, as well as our plastic surgery team and radiation oncology team, all providing care in Brooklyn in multiple locations. So within the city of Brooklyn, there is no spot that you won't be able to see a provider. Here are the leaderships of that program. Dr. Zelenko, I mentioned, myself. I see benign disease, high-risk disease, breast cancer diagnosis and treatment, and do general breast surgery. Dr. Diabrio and Dr. Daniels, all providing personalized care from genetic profiling and targeted therapy, pretty much comprehensive services from screening to survivorship right here in Brooklyn. In terms of referring, how do you refer to us? From the breast surgeon's perspective, we see all types of breast disease. If a breast is involved, whether it be benign disease, high risk, or cancer, we see these patients and we see them quickly. For breast cancer patients, we see them within 24 hours between the two of us. If it happens to be on a Friday and we get a phone call, we both have the policy of calling the patient if we're not able to see them right away, just to allay fears and make sure they understand that things will be taken care of in a system that has high quality and that they will be well cared for. The types of surgeries that we do include surgical biopsy, everything all the way up to a mastectomy, including oncoplastic reduction. This is basically doing a lumpectomy and a reduction for some patients with the breast size. I have listed here how you refer, and I wouldn't be remiss if I didn't mention our clinical support team, who's been very incredible in making sure all this happens. We provide what we provide because Brooklyn deserves it. Thank you. I'm now going to introduce Dr. Diabrio.
Thanks, Donna Marie. So I'm Nina Diabrio. I'm a breast medical oncologist and currently leading the medical oncology side of things in Brooklyn. But my other hat is also division chief and site director at our PCC Sunset Park location, where we have very close interaction with this wonderful group of specialists you've seen here already, and with the hospital, and we're growing services as we speak. I will also talk about clinical trials at the end of this presentation, so stay tuned for that. To reiterate what my colleagues have said, we have a footprint in Brooklyn and we'd like to keep growing it using existing resources as well as adding new people as we grow, so that no matter where in Brooklyn you live, you have access to a medical oncologist in breast cancer and other cancers. And this is where that footprint lives. And I've included Queens there because some of our colleagues who work in Queens do see patients who live in those borders. I personally worked at NYU in Mineola for 15 years. And so I can tell you that we're very seamless in patients traveling across the boroughs. And now they have options. They don't have to go just to Manhattan. They can go to any of our locations. So this is our core faculty. I know Donna Marie's alluded to some of these. At PCC Sunset Park, there's myself, Dr. Elena Katz, and Dr. Yael Simon, who you'll hear from next, who also does our high-risk program. So we offer the gamut of services, and I haven't really gone into details of every single one, but the one thing that I'd like to underscore is breast cancer is not one disease. Many of you in this room are aware, you're aware of that every patient's different, there's different kinds of breast cancer. And so we practice exactly what you've heard in these big studies. We want personalized medicine. We want to use precision medicine. We want to profile the tumor. We want to profile the genes. And if we have access to a clinical trial for that particular tumor type, we want to deliver that. So standard of care approach, providing compassionate care, as well as access to cutting edge clinical trials. So this is our core faculty again in Brooklyn. As Donna Marie alluded to, breast cancer is a disease that is fairly common, unfortunately. We do need a huge army of people. So in addition to our core faculty at Sunset Park, cannot underscore the importance of our generalists, our group who does more than just breast cancer, in our Cobble Hill locations, in our 4th Avenue location. Some of these doctors may be familiar to some of you in the community. They've been here for a long time and have been spearheading the treatment of these cancer patients. But now they also have the option to refer to us for tertiary or quaternary care and for clinical trials, and our Midwood colleagues that you can see here. So I'm going to move very quickly to Dr. Zelenko, and I promise I'll come back to clinical trials, including in breast cancer at the end.
Good morning, everyone. It's a pleasure to be here. My name is Natalie Zelenko. I head the breast imaging section in Brooklyn and Staten Island. I could give a whole talk about breast radiology in general, but I was told I could only have 4 slides, okay? So this is gonna be very, very limited, okay? This is our, first of all, let me just say that the radiology department in general is really excited about the expansion of our breast imaging footprint in Brooklyn over the last 2 years. This is our Brooklyn dedicated breast imaging team. We have 6 dedicated breast radiologists. All they do is breast imaging, okay? And you will see our names on the reports you receive, and you will hear from us when we call to discuss your patient's care. We offer multimodality screening and diagnosis, okay? Let me just underscore this. The quality of the equipment and our capabilities are of the same caliber as everywhere else within the NYU system. This is what is available to our Brooklyn patients. We offer screening with mammography, ultrasound, and in the high-risk setting with breast MRI. We offer the same modalities for our diagnostic patients, so patients who are undergoing additional workup after their screening, or patients with known diagnoses who require ongoing imaging. We perform our biopsies using all of the modalities that are at our disposal, stereotactic or currently actually digital tomosynthesis biopsies, ultrasound-guided biopsies, and MRI-guided biopsies. And we use the same technology for preoperative localization in the appropriate clinical settings to help our surgeons. These are our locations. These are very similar to the other slides you've been seeing. Our 2 main diagnostic locations are at Cobble Hill, which is circled in green, and that's in the same building as our PCC site on 70 Atlantic Avenue. And then circled in orange is our Fort Hamilton site, which is very close to the Sunset Park location and also very close to the Bay Ridge location where we actually perform MRI-guided biopsies. And then the D site is very close to our Midwood location, and that's a screening-only site.
These are our teams at our Cobble Hill location and our Fort Hamilton location. This is current because this was October. We just had it. It was Breast Cancer Awareness Month. So here we all are. And really, these people are so dedicated to providing exceptional experience for our patients who are, worried and stressed when they come in for their breast imaging or for their breast biopsies. We really understand how complicated it is, how emotionally, confusing and just a strain on our patients, and we really try to make them as comfortable as possible. And I'm really happy to say our patients, all of them, say that they've had an amazing experience. Okay, you want to finish up?
Give it to radiology to give it back to surgery.
Hey, is that what we do?
It is what we do. I want to thank you for the opportunity to be here and talk to you about it. It really is important to remember that the reason this even exists, this is even important, is because breast cancer is very, very common nationwide, but in particular in Brooklyn. If you compare the rates of breast cancer in Brooklyn to Manhattan, surprisingly, we have a much higher incidence of breast cancer in Brooklyn. And in fact, in the past 5 years, that incidence has increased by approximately 8%. So NYU, seeing the vision and recognizing that, decided to provide the quality care that is due to patients in Brooklyn. Thank you.
So my name's Yael Simons. As you heard, I'm one of the breast medical oncologists here, but I'm going to talk a little bit about another department that I'm involved with, which is our high-risk cancer genetics department, which we call the REACH program. And I promise I'll get us to a little break soon. So what does REACH stand for? It's Risk Evaluation, Assessment, and Care for Hereditary Cancer. So broadly, this provides high-risk cancer surveillance and management for individuals and families that have been identified as being at increased risk for developing cancer through both genetic testing or through risk assessment. And we provide patients and their managing providers with guidelines, recommendations for treatments, and strategies to reduce risk and prevent cancer. So more generally, kind of what does this program provide? So we offer genetic counseling, patient resources and support, access to cutting edge genetic testing options. We do insurance pre-authorization check to ensure that cost is not an issue with regards to getting genetic testing done. We then provide interpretation of the genetic test results, personalized cancer risk assessment, individualized cancer screening plan, and risk reduction strategies. We have patient navigation for all our high-risk management strategies, and then we have opportunities for cancer genetics research as well. So the program is kind of divided into two components. So the first part is the Cancer Genetic Counseling Clinic. So that would be for people that have either a personal history of cancer or a family history of cancer. They would meet with a genetic counselor to talk about genetic testing for hereditary cancer risk. The genetic counselors provide pre-test counseling, so they'll go over the criteria for testing, if someone meets that criteria, what's involved in the testing process, and then they'll help facilitate the testing. And then they will then have a post-test counseling visit where they'll go over the results. The other thing that our counseling clinic offers is what we call cascade testing, which is really important. So that's if patients are found to carry a germline mutation, we generally recommend that their family members who also may be at risk for carrying that mutation are tested. And so our counselors can actually help facilitate that additional testing of family members. The other component is the REACH High Risk Clinic. So that is for patients that have been found to carry a germline mutation or for people that are considered at higher risk just because of their family history alone, even if they test negative. There, we provide longitudinal follow-up and management for these high-risk patients. We utilize screening and risk-reducing strategies for early detection and ideally cancer prevention. So the list is getting longer for who we really should be thinking about for genetic testing. The reality is, if you think someone should, you should just refer them to us and we can kind of decide if that, with the patient, if they're appropriate. But these are just some people where we would definitely think about genetic testing. So anyone with a personal or family history with a close family relative of either a breast, uterine, colon cancer under the age of 50, any ovarian cancer or primary peritoneal or a triple negative breast cancer at any age should be thought of for genetic testing. People that have had multiple types of cancers or someone that's had breast cancer in both breasts, someone who's had a colonoscopy that's identified many polyps, people with multiple relatives on the same side of the family with certain cancers that we may think of that are linked together, so breast and ovarian or colon and uterine, any male breast cancer, any pancreatic or metastatic prostate, anyone with Ashkenazi Jewish ancestry that also has a history of breast or prostate cancer, regardless of their age. And then anyone with a known family member that has a genetic mutation, again, we'd want to identify, even if they themselves don't have cancer, we would want to identify if they carry that same gene. So I thought it might be helpful just to give a couple examples of some patients I saw in my clinic like a couple weeks ago, just to give you an idea of the process that they went through and what we were able to kind of offer them at NYU. So this is a 31-year-old female. She has a history of breast cancer in her mother, 2 of her aunts, and her maternal grandmother. She also reported a family history of pancreatic cancer in a maternal aunt. And after her primary care doctor took a family history, she was referred to the high-risk REACH clinic. So she first met with a genetic counselor. They went over the process of genetic testing. She elected to do that. And then this revealed a BRCA2 mutation, which we know is associated with an increased risk for certain cancers. So she was then referred to a high-risk provider to discuss screening and risk-reducing strategies. So I saw her as a breast oncologist. We went over kind of all of the cancer risks that we think about with BRCA2, but focused on the breast cancer screening aspect and any risk-reducing surgery options. She elected to pursue extra screening, and so we ordered breast MRI and mammography, and we'll follow her moving forward for her extra breast cancer screening. But then she was referred to the other relevant specialties for continued follow-up for the other risks that we think about. So she was referred to Gynecologic Oncology to talk about ovarian cancer screening and risk-reducing strategies, to our pancreatic cancer screening clinic, to dermatology to talk about melanoma risk. We discussed fertility preservation and different pre-implant genetic testing options for IVF or testing for BRCA in embryos. And so she was interested in learning more about that. So we referred her to our oncofertility clinic. We discussed lifestyle modifications for lowering cancer risk, and then referred her to our NYU BRCA support group, which is an amazing resource that we have for our young BRCA carriers, where they meet once a month to kind of discuss openly their shared experiences. And I have a number of patients that use that resource and really think that it's a helpful thing to have. So another example that I thought might be helpful was actually of a person who had negative genetic testing, but was still thought of as high risk, and so would be appropriate for us to see. So this is a 44-year-old female. She had a family history of breast and uterine cancer in her mom, colon cancer in her maternal uncle. And again, she was referred to our clinic by her gynecologist. So she met with our genetic counselors, underwent genetic testing, and this actually returned negative. But because of her family history of breast cancer, our genetic counselors use what we call risk models to calculate her estimated lifetime risk for developing breast cancer. The one that we often use is called the Tyrer-Cuzick model. So this estimated her risk to be 27%, which is what we would consider high risk, something over 20%. And so because of that, even though she had negative genetic testing, she was referred to our clinic to discuss that in more detail. So I met with her. We talked about a little bit more about what that risk means, the recommendations for extra breast cancer screening because of that, and then again ordered her breast MRI and mammography, and we'll follow her moving forward for extra breast cancer screening. We also talked about lifestyle modifications for lowering cancer risk, and then some other age-appropriate cancer screenings and screenings related to her family history. So the best way to refer to us is in the NYU system. It's pretty easy, just through the ambulatory REACH cancer genetics order. There it will actually have a drop down to ask you if the patient's had genetic testing already, and if they have, it kind of helps us facilitate which group they need to be seen by. Outside the NYU system, there's a phone number or a fax that you can refer if needed. The team is actually really large, so I just highlighted a few people here. So Dr. Mina Sigaretti is actually the director of the REACH program. Yulia is one of our high-risk APPs that works with us in the clinic. Rachel Chambers is the manager. She's a genetic counselor, but she's also the manager of the high-risk cancer genetics program, as well as Liz Lewis, who's the clinical supervisor for the genetic counselors. We have a lot of collaborating physicians, but just a couple highlighted here. Dr. Gonda is the head of the pancreatic cancer screening clinic. And Dr. Julia Smith is another medical oncologist high-risk provider. We have 11 cancer genetic counselors, so the wait time is usually very short because we do have a very large staff. And we have 7 genetic counseling assistants as well. In Brooklyn, I physically see patients in Sunset Park. I also see patients in Manhattan, but the reality is a lot of what we do is counseling, and a lot of that can be done virtually. And so we are able to really see patients in any location that they are in Brooklyn through telemedicine visits as well.